Hi everyone. Thanks for joining me on this, webinar or this Zoom meeting on gynecomastia and steroids. I'm glad to see that some of you had joined us, and probably throughout the session, people will be joining in and texting or messaging me questions. So I'm going to see if I can get to some of them as we go, as much as possible. If not, I'll save those questions for next time and we can do this again. But I wanted to do this type of forum because I often get emails or messages through Reddit or some of the other social media and questions about gynecomastia and steroids, because I also do the testosterone replacement therapy and performance enhancement program for XSculpt, and I wanted to be a lot of the same questions come up over and over, and I wanted to be able to just be able to provide a way for people to just look it up. I'm happy to answer any questions, but watching this video hopefully will answer a lot of the questions that all of you may have or share. Okay, so if you have any specific questions, please send me a message through the Zoom portal, and I'll try to get to it today. I'll be answering about maybe 3 or 4 questions in the time allotted, and we'll go from there. Okay, so obviously the first question is why, and most people already know, is why do people who do steroids get gynecomastia, and mainly basically it's because, long story short, it's estrogen is a female hormone, but it's made from testosterone, right? There's a process called aromatization, where the testosterone is turned into estrogen from the enzyme aromatase. Now, this enzyme is generally found in fat cells of the body. That's where it's most prominent. And so this enzyme turns testosterone into estrogen. That's why it's very important that should you do testosterone replacement therapy, or if you're on some sort of steroid cycle, that you consider taking aromatase inhibitor in the form of usually something like Arimidex, which is a trade name, or aromatase, which is anastrozole, which is a generic name. And what this medication does, it prevents that aromatization from testosterone to estrogen. Now, by doing so, by blocking that pathway, by blocking that enzyme, the testosterone stays testosterone, doesn't turn into estrogen, and the risks or the chances of you getting gynecomastia dramatically reduces. Now, does it decrease completely? No, it doesn't. But it does help a lot. Now, it's very important though that you do some sort of laboratory monitoring while you're on steroid therapy, or if you're doing a cycle, as much as possible. The reason why is because you don't know. Well, there are several reasons. Number one, you don't know if you're doing enough. If your dosage of your AI or aromatase inhibitor, your dosage of AI is enough. Often we start our guys on 0.5 milligrams. What if you require more? What if you require 1 milligram or 1.5 milligrams or 2 milligrams or 1 milligram every other day, or 1 milligram 3 times a week? That's very important to know, because you might not be taking enough. And so if you're not taking enough, then your estrogen will be high, and even though you're taking an AI, you still will develop gynecomastia. So it's important that laboratory monitoring is there. That's number one. Number two, it's also important to make sure you don't bottom out your estrogen. Estrogen is very important for guys to have. No estrogen is not good, because estrogen serves important functions in the body. So without estrogen, you can get osteoporosis, you can get heart problems, and so you can get, and so it's important to have estrogen. It's also when you have no estrogen in your body, you can have a lot of mental effects. You can get sexual dysfunction. You can also get very, very irritable. Estrogen is what, you can get very, very irritable. Estrogen chills guys out when they have testosterone. It balances the testosterone mentally, so you don't get, very aggressive. You don't get very angry. And so when you have no estrogen in your system, or very, very low estrogen, then guys have a tendency to have that side effect of irritability. And so it's also, that's why it's important to know what your estrogen levels are while you're on steroid therapy, or testosterone therapy, or whatever you're doing, so that you don't bottom out your estrogen. So estrogen too high is bad, estrogen too low is bad. Not only too high, not only because of gynecomastia, but you can also get other side effects of estrogen excess, which is water retention. You can get mood disorders also. So, and those are, and you can also get erectile dysfunction and lack of libido because your estrogen is too high. And so you don't want to have your estrogen too high and too low. So it is something that should be monitored, particularly by a professional, or especially by a professional, so that you don't have either swings. Now, there's always been some debate on what's the best estrogen level for you or for an individual. A lot of people say, run your estrogen on the lower side because you don't want the effects of excess estrogen. And but the more current research saying it's better to have more estrogen than less estrogen, which in my experience, I tend to agree with. You want to, guys just seem to feel better when they're a little bit on the higher side, within the normal range, but on the higher side. And what am I talking about? Like an estrogen of around 50, 40 to 60 is where I like to keep my patients. Some physicians will want to keep their patients around the 10 to 20 range. It's really just a matter of I think experience and how the patient feels. However, that being said, if you are one of those individuals who are so dialed into their physiology, some guys feel awesome at an estrogen of 60, and there's some guys who feel awesome at an estrogen of like 15 or 20. It's really a matter of how you feel at what particular level, and you really have to be cognizant of how your body is working at certain hormone ranges, and the only way to do that is to check your labs regularly. So that's very important. It's so common where I see guys come in, they want to get, they want to be on testosterone replacement therapy. They've done cycles in the past, but they've never done their lab work. But they tell me that they were on an AI and they did a PCT, all that stuff. The problem is they were never monitored in the lab, so I don't know if the AI dose that they were doing was adequate. I don't know if they were doing too much. I don't know if they were doing too little. I don't know if their PCT was adequate, because we have no idea if they were able to restore their hormones to normal levels. So there's that. That's a long-winded answer. To a simple question of why do guys get gynecomastia on steroids? Now, which steroids are there? Steroids that are more prone to causing gynecomastia than others? Sure. Well, I don't know, to be honest. A lot of the steroids are more or less a variation of testosterone. Often it's just a matter of changing one of the terminal ends of the carbon that changes the actual mechanism of how that particular testosterone molecule works. However, in general, they're all somewhat of a testosterone type base, which means they all generally aromatize. Now, one steroid in particular we should talk about is decadurabolin, or nandrolone, which is the generic name. Now, guys tell me all the time, is like, hey, I was on nandrolone, or I was on decadurabolin, I was doing 600 milligrams a week, but I was on the AI, but I still developed gynecomastia. I monitored my labs, my estrogen was like 20. Why did I still develop gynecomastia? You have to be aware that some steroids also raise your prolactin levels, and prolactin can cause gynecomastia as well. Prolactin has its own set of side effects, very similar to gynecomastia, but one of the most infamous one is causing erectile dysfunction, or known as dick, which usually starts to happen at 400 to 600 milligrams a week, and that's why if you are on that type of a dose of steroid, it's important that you consider taking your physician put you on a medication, cabergoline, that blocks prolactin. Now that being said, of course, I'm a physician. I don't condone the use of steroids for performance-enhancing reasons, and many, if not all, my colleagues are the same way. However, we have to be realistic in that our patients and some of our individuals do what they do, and they get their medications from sources outside the normal realm. However, it's my priority is to take care of my patients, and I always encourage my patients to make sure that they do it correctly and safely and monitored. And I am a realist enough to know that that doesn't always happen every day, but it is upon me to educate everyone that there are risks about what you do. And again, I don't condone the use of steroids without being monitored appropriately and at illegal dosing that's not supported by the medical community, because there are bad side effects that are irreversible, and it is a danger to your health, and you should be just aware of that. And as long as I educate you on those risks, I think that that one of my jobs is done. So there's that disclaimer. Let's see. There was something else I wanted to mention about that. Okay. So the next question about gynecomastia and steroid use is, can you cure gynecomastia with medication alone? Okay. For example, if your gynecomastia were to develop, can you take an aromatase inhibitor or a peripheral estrogen blocker like tamoxifen? Will that cure the gynecomastia? Okay, good question. Now, gynecomastia, if it's treated adequately and when it's discovered early, yes, you can cause it to regress by using those medications. However, if you have to take care of the source, right? So if you're doing an X amount of testosterone that's causing your gynecomastia, yeah, you could take an aromatase inhibitor and a tamoxifen, and your symptoms of gynecomastia should go away. But you would have to be on those medications while you're on your steroid therapy, or else as soon as you stop the medications, the gynecomastia will come back. You can't, there's no technically a cure for it, but you can always, you can drastically reduce the symptoms. Now, should you get gynecomastia while you're on some sort of steroid therapy, if you get gynecomastia while on steroid therapy, that means you're predisposed to getting gynecomastia. That means you do likely have an underlying gland there, and it's just a matter of it being stimulated by estrogen to make it for you to get a flare up. So you'll always be predisposed to getting. That means you had enough estrogen at some point to form the gland, and that gland will stay there. It's just that you can really make those symptoms subside. And essentially bring them to a point where you either don't notice it or it doesn't bother you. To answer the question, can you cure gynecomastia without medication? No, you can't cure it. The only definitive treatment for gynecomastia is actually surgical, but you can definitely relieve yourself of the symptoms to a point where it's not bothering you with medications if treated early enough. Now, the issue comes, like, let's say you've had gynecomastia Now, so the way that it works is if you catch gynecomastia early enough, you can take care of the symptoms of tenderness and pain and inflammation. But if your gynecomastia has been present for a year, it becomes permanent. And the reason why is because what happens is that once you hit that mark of around a year, more or less, the breast gland starts to develop what we call stromal tissue, or in layman's terms, scar tissue. Okay, once that scar tissue forms, or once that fibrous tissue forms, that becomes permanent, and no medication will get rid of it. You can't use an aromatase inhibitor. You can't use a estrogen peripheral blocker. So it becomes permanent, and at that point, surgery is definitely the only thing that'll take care of it. So, for example, let's say you've been on steroid therapy, you did a couple cycles, you developed gynecomastia, and it's just been present for about a year or more. You may get flare-ups, you may get tenderness, you take an AI, and the flare-ups go away. Will the mass go away? Will that ball under your nipple go away? No, it won't, because you've developed you've come to a point where you develop the fibrous tissue, and that will be permanent. Sure, you can stop the symptoms of tenderness and perhaps prevent its progression or growth, but you won't be able to completely eradicate the actual mass itself. Okay, so there's that. Let's see. I think I answered this next question. Is gynecomastia permanent once it forms? I think I just answered that. Only once, usually when it becomes long-term, like usually after a year. Around a year, it becomes permanent. So if you develop gynecomastia, as soon as it forms, you want to be aggressive about taking care of it, because at that point it's only gland. So you want to be aggressive about treating it with as some sort of estrogen blocker, and then doing what you can to make sure it doesn't come back, like make sure your estrogen stays within normal limit while you're on testosterone replacement therapy. Or if you're doing a cycle of something, then consider ending it early or stopping it, or otherwise, you can end up with a permanent problem. Okay. The next question is, I answered the next question, do all steroids cause gyno? I answered that question, I think, already, regarding yes, because most performance enhancing, and physique enhancing steroids are some sort of testosterone base, and if it is, then it does aromatize, and so it does aromatize. So if it does aromatize, then yes, it will cause gynecomastia. Obviously, there are other performance enhancing medications like growth hormone and stuff like that, and that doesn't follow the same pathway, that doesn't aromatize. So growth hormone type performance enhancing medications don't cause gynecomastia because there's no estrogen pathway there. So that kind of medication won't do it. So, but yeah, testosterone based steroids will definitely cause gynecomastia. Now, one of the questions, obviously, because I'm a surgeon, what surgical options exist for gynecomastia? Well, there's actually plenty. A lot of it depends upon what grade of gynecomastia you have. Now, there are 4 grades. Grade 1, where you just have what they call basically puffy nipple syndrome, is where the nipple just kind of pops out from the skin. Usually these individuals are very lean with a very low body fat percentage, but their nipple just kind of like comes to a bullet point. That's usually what grade 1. Now, grade 2 gynecomastia is where you have less than 300 cc's, 300, 500 cc's of fat, as well as a breast gland around the nipple. So it's like a kind of a breast mound, and that's probably the more common that we see. Now, grade 3 is where the nipple, where the breast is larger, so that the breast starts to sag, and the nipple is somewhere around what we call the inframammary fold. So it's a larger breast and it starts to sag. That's a grade 3. And then grade 4 is where the breast is so large the nipple hangs at or below the inframammary line, which is down here, and that's an advanced form of gynecomastia. So it depends upon what the surgical option depends upon what grade you're at. But for bodybuilding, it's either grade 1 or grade 2 that we see. Advanced bodybuilders, it's grade 1 definitely. but grade 2 is probably the more common ones we see. Now, for the surgical options range, like I said, based on your grade, from just excision of the gland itself under local anesthesia, all the way up to grade 4, where we call it bilateral mastectomy, where we have to remove the loose, not only the breast tissue, but as well as the loose skin that's associated with the hanging breast. Now, we do see this with bodybuilders and guys who like really big, really obese or overweight. They went on a weight loss journey or a health journey. They lost a bunch of weight. They got like super lean, but then they have a lot of loose skin, and so what will happen is their gynecomastia basically is just skin, the breast gland, and it's just hanging down. Their physique looks awesome. It's just that they have this gynecomastia. And in those instances, we do what we call a mastectomy, where we would excise all that skin, and then what we do is, and then what we call a free nipple graft, where we remove the nipple from the old skin and put it on the back on the chest in its new home. For grade 2, which is the most common we see, is we do basically at XSculpt, we do high def liposuction, as well as obviously gland excision, where not only we do liposuction of the breast gland, but we do high definition work of the all in chest to enhance all the cuts and stuff like that. So that's the most common procedure we do for bodybuilders. Grade 3, we often combine it with some sort of the liposuction, high def liposuction and gland excision with some sort of skin tightening procedure. We use Vaser Lipo, which is an ultrasound type liposuction, where we basically break down or melt the fat and suck it out, which causes some skin tightening as well. We also use, not only me, but a lot of other surgeons who do this procedure cause J-plasma removion, where it basically burns the skin on the inside, causing increased collagen production and tightens the skin. And so those grade 3s, we do that for grade 3 individuals. It gets a lot more in depth, but just to touch a surface on that, that's basically what we do for gynecomastia. But again, it depends upon your grade. All right, so I think I answered most of the questions, the most common questions. Now, if you're interested in seeing me for a consultation or for an evaluation, please visit xsculpt.com, and you can contact us. Fill in the form there for virtual consultation. You can reach out to me directly at Dr. Adajar at XSculpt.com. That's Dr.Adajar at XSculpt.com, and I'd be happy to to respond. You can email me your pictures. I'll take a look and see how I can help you. If you have any questions on anything talked about, or if there's questions you want me to answer in the future to do another Q&A, I'd love to do it again. So please email me those questions. I'm going to post this video on YouTube as well, and you can maybe leave some comments below and about gynecomastia and steroid use, and I'd be happy to address those at the next Q&A. All right, thank you very much for joining me on this webinar, and if you like it, let me know and I'll try to do it again if I get good feedback on it. All right, thanks, bye.